Hello, everyone. Welcome to the GRAPPA EULAR Virtual Congress Highlights 2026 meeting. We're all very excited to be here, and we are very glad that many of you are joining us in this event. The overarching goal of the GRAPPA Virtual Congress Highlights meetings is to provide an opportunity for in-depth about the newest scientific evidence regarding psoriatic disease. So we have many different international major congresses, such as the EADV, the AAD for the dermatologists mainly, EULAR and ACR for rheumatologists mainly. So we hope to involve the GRAPPA members and non-member physicians and scientists who are interested in psoriatic disease. And what we want is to create the most valuable exchange of ideas and knowledge. So in this session, we are very, very happy to have three Y-Grappians that are going to present their selected abstracts from this year's EULAR Congress. So I'm handing over to Fabian.
Yes, Margot, many thanks. So also welcome from my end. I'm very happy to be here again with you guys to hear the most relevant abstracts that were presented at EULAR. It was a very busy meeting. We were just discussing backline that I was not able to see everything, and therefore I'm very, very thankful that the wonderful three young Grappians presented the curated highlights for each section for basic science, clinical highlights, and the newest updates on treatments, and that we can just sit back and relax and listen to their brilliant talks. They were supervised by senior experts. Very thankful for all the dedication and time that you invested also in supervising and guiding the young Grappians. And last but not least, I'm very happy to welcome you, Margot, for the first time here on my side as a co-host and contributing with the dermatological perspective. I think this is always really valuable when we're speaking about the newest highlights on psoriatic disease, that we are able to have an interdisciplinary exchange on the relevance. Maybe you hear stories today that are very old for you because you have these drugs for a long time around in your clinical practice, or the other way around, that you hear something that is very interesting and can be the future for dermatologists, because here in this case rheumatology was a little bit up front. And it's not only us, the experts, but we also have Wendy Wagner. Wendy is a PRP within the GRAPPA network. We're really happy that she is here with us and will substantially contribute with the patient perspective. And without any further ado, I think we can get started. Here is the agenda for today, very packed, but still we will have time to discuss the highlights that were presented. And here we just want to invite all of you also addressing the questions in the Q&A section that you find in the webinar, so we can direct your questions directly to the experts and then have a vibrant discussion around the topics. And now I think we can get started. Margot, what do you think?
Yes, it's time. So thank you very, very much for the opportunity to be here. I'm very, very excited. I have presented in the past some of our abstracts from the dermatology congresses. So very brief dermatologist at Barts Health in London and honorary senior lecturer, and very excited because we are here all together to talk about psoriatic disease. So we're going to start. First, I'm going to introduce Isaac Cheng, who will present the EULAR highlights basic science. And his mentor was Marlene van de Sande, and she's going to join him for the questions and answer sessions. So a brief introduction for Isaac. So Dr. Isaac Cheng has been actively involved in rheumatology research at the Rheumatology Research Center within the Department of Medicine and Therapeutics at the Chinese University of Hong Kong since 2014. His research has focused on comorbidities in patients with inflammatory arthritis, and he has focused a bit more on cardiovascular disease and radiographic damage. He has used advanced imaging techniques and he has experience in multi-center clinical trials, but also regional registries. Since 2018, he has served as a facilitator of the EULAR SPA registry, and he has received numerous awards, national and international, and he's actively engaged in the wide GRAPPA community. So we are very happy to have him with us today and very honored. So Isaac, the floor is yours.
Thank you very much for your kind introduction. And can you see my slides? Okay,
Yes.
so actually, as introduced, I'm actually focusing on imaging and also some other research. And actually, I'm not a basic scientist, but I will try my best to summarize some key highlights from the EULAR for you in a simple way. And I will not go into a very technical details, and just want to share some key highlights and the concept of these studies with of you. So to start with, here's our disclosures, both mine and also my supervisor, I think my mentor's disclosures. So to begin with, the first abstract I share with you is about the abstract on the single cell profiling of skin and synovial biopsy, which identified opposing interferon alpha and beta pathway regulation in patients with psoriasis with arthralgia and also in PSA. So, in this study was conducted by this group, a brilliant group of people. So, to begin with, we know that about 30% of patients with psoriasis might develop PSA, and this subset of patients who had psoriasis as well as arthralgia actually represents patients at high risk for the transition. But then we also know that fibroblasts are playing a key role here, which are key stroma cells in the skin and the synovium. But what is less known is what is the actual mechanism and the biomarkers for the transition to PSA. We do not know much about its process, and therefore, in this study, the team were aiming at profiling the skin and the synovial fibroblast populations in patients with psoriasis with arthralgia and also PSA patients using a single-cell RNA sequencing technique, and to compare the transcriptional program to see if are there any pathogenic signatures. So here's the method. So they have patients with psoriasis with arthralgia to have the skin biopsy, to have the single-cell RNA sequencing, and also have the synovium biopsy, and also they do the skin the transcriptomics for the skin biopsy. So the different clusters of cells were identified with different gene marker, and we can see from this table. So especially for the fibroblasts here, and also the myeloid cells using these markers. So I'll go into the results. So here's firstly is about the skin biopsy. So for those who are less familiarized with this kind of UMAP figures, each color here is actually representing clusters of cells here. So in this study, they identified different clusters of fibroblasts in the skin. So there's quite some heterogeneity, and you can see there are some universal one and also some immune interacting fibroblasts, which are quite important and we introduced in the subsequent slides. And here in the immune interacting fibroblasts here, this study showed an increased abundance in both the PSA and those patients with psoriasis and arthralgia when compared to those with healthy skin. So we can see from this bar chart here, so the blue color, the dark blue and also the light blue here is representing population of the synovial fibroblast population with the immune interacting properties here. So I think it is and this immune interacting fibroblast is actually appearing in those patients with arthralgia already, but they do not have PSA yet. And next, we move on to the synovium And here is also synovial biopsy. We can see on this map here, there are different subpopulation uh, in the synovium. And we identified three lining and one intermediate and five sublining population of the fibroblasts in the synovium. And different from the skin biopsy, the different proportion of the fibroblast subpopulation were comparable between the patient's groups and the healthy control. So those subpopulation are quite evenly distributed here. And the next, after identifying different subpopulation through the single-cell RNA sequencing, the group had also did the transcriptional analysis here in the skin. So in the skin, from this graph, we can find that the immune interacting fibroblasts shows the largest transcriptional difference between patients with PSA and psoriasis with arthralgia. So if it's towards this direction, those are the genes that are upregulated in PSA. In the left direction, it is upregulated in those uh, patients with psoriasis and arthralgia. So we can appreciate there's a huge heterogeneity in terms of the gene regulations in those in the immune interacting fibroblasts. And they also find that the PI16 plus fibroblast shows distinct gene expression patterns between the patients groups, which mean they have psoriatic disease versus healthy controls. And this is talking about how that is this is a gene enrichment score for the relationship with the interferon alpha or beta signaling pathway. So it's enriched there, and from this study, they found that in those skin fibroblasts more prominent in the CCL19 subpopulation show that downregulation of the alpha and beta signaling pathway in PSA. So it is downregulation of this pathway. So and then, but then when we are looking into the synovium here, we find that the sublining of POMP is having the largest transcriptional changes, both in comparing the patients with PSA versus psoriasis with arthralgia. And this is in the case of synovium. And more interestingly, when we compared to the skin fibroblasts, we see the pathway is actually upregulated in the skin, which contrasts the results of the synovium. So they also look at different kind of enriched genes, and they find that this HLA-A, HLA-B, and these genes shows a divergent expressions in the skin when compared to the synovial tissue. And here are some postulated explanation for the difference in terms of the pathway. So it might be related to the TGF-beta, in which it was suppressed in the skin, but then it is actually activated in the synovium, and this is a postulation. So to conclude, in this study, they find that mapping skin and synovium to cell landscape using the single-cell sequencing, they identify different subpopulation of the fibroblasts with distinct transcriptal signatures, and they identify opposing interferon alpha and beta pathway regulation in skin and the synovium, which may represent an early mechanistic driver of progression from psoriasis to PSA. So that is about the first abstract. And moving on to the second abstract. So this one is about circulating pre-osteoclasts, which are primed for osteoclast fate and synovial tissue homoimmune psoriasis and in PSA. So to begin with, and this is about osteoclasts, which we are moving on about the bone destruction in PSA, which osteoclasts are playing a very prominent role, and they're derived from the monocyte precursor, but then we do not know how these precursors actually enter the joint, and the leukocyte infiltration into the synovium is also poorly understood. So this study tried to give us some more new insights about these cells. So the objective was to characterize the circulating pre-osteoclast cells in human and identify the role, and is the key hypothesis. So they think that these osteoclasts is primed to ready to do some trouble. So and they are actually derived from the monocytes with these two the dendritic cell subset, and they were already in the circulation, and they preferentially recruit to the PSA joint and have the bone destruction in the cell. So that was their hypothesis, and they use different ways to investigate if this hypothesis is true. So they actually identified the osteoclast subset using the mass cytometry. So they actually identified this so-called pre-OC state, the pre-osteoclast. So it is derived from the monocyte and enriched for MFATC1, and they are different from the monocytes, and they resemble virtually the osteoclast mediates. So this is the key message is the new state of pre-OC, pre-osteoclast was identified. And so they actually compare this in the blood of patients with PSA and also heavy control and also psoriasis only, and they see a increased population of this pre-osteoclast. And actually, they also have some virtual experiment. So this is talking about when compared to the pure classical monocyte and also the pre-osteoclast. So it is outside. The human is in the lab. So when there's still some growth into the osteoclast without endogenous rankle, which we know like a rankle is a stimulation for the development of osteoclast. But then even without the rankle ligand here, the pre-osteoclast can still develop into the pre-osteoclast can still develop into the osteoclast. So it is independent of the rankle, which means they are primed to develop into the osteoclast. And here's what their study is doing. So they recruit healthy control and PSA donors, and they collect the bloods, and then they actually add the radio labeling to the blood here, which can help us to label the monocyte. And then they infuse this to the human blood to the donor's body. And after that, they have the SPECT imaging, and they have sequential image and to see if they can actually identify the radio-labeled monocyte. And they also did the biopsy, the synovial biopsy for PSA patients. So here's the image here, and here's a healthy control. We can see there's no uptake to the joint. But then in those with PSA, you can see about the dark layers here, which are the uptakes to the knee, to the ankle, and also to the wrist and to the MCPs. And that was also correlate with the ultrasound finding with synovitis. And from here, we can see in a healthy control, the uptake to risk actually decrease over time. But then the red lines here showing patients with PSA, that actually the uptake increase over time. So this means that these radio-labeled monocytes really enter into the PSA joints. And they also did the spatial transcriptomics here, and they identified increased population of the osteoclast, and you can see from the image here, and that's actually pick up inside the cells. And they also have the radio labeling. So it's really in this enclosed area, which tells us they really migrate into the tissues, and they also count the number of CD99 positive tissue, the radio labeled cell here. So to conclude, in this study, I identified the new subset called the pre-osteoclast that form the osteoclast without further endogenous rankle, and they the so-called the bad guys who are primed for migration in the synovial tissue in psoriatic disease. And it's also increased in the blood and the synovial tissue in these PSA patients. And so it's telling us something new about the pathway. And well, quickly, I will move on to about the third abstract, which is about from a disease-centered to a tissue-centered care in PSA. So it's the clinical impact of synovial biopsy-driven therapeutic stratification. So this is more translational research, and hope that would be easier for understanding. So we have current limitation that 40% of patients might fail to respond to the first biologic, and we can still see a substantial proportion of them remain refractory after multiple treatment, and we are lacking validated predictive biomarker for us to choose the treatment. And it's synovial tissue giving us some information. So we know that there is still pathological scoring system for the synovitis from the biopsy. And we also know different kind of cells, myeloid cell, the lymphomyeloid, and also the immune cells from there, which can provide actually very accurate information about the inflammatory burden. And they have a piece of information is that a minor haplotype characterized by the strong CD117 positive expression, which actually represent a subpopulation with mast cell and monocyte active patients. So this group of patients might be at a high risk, and they may also indicate that the IL-17 and 23 pathway may play a more central pathogenic role. So the research question they raised would be, could we actually shift from a disease-centered trial and error approach towards approach using a tissue-centered and biologically informed precision medicine model? So this is a pilot proof of concept study to see if this might be possible. So they compare the clinical effectiveness of biopsy-driven therapeutic strategy, and they compare with the standard approach. And they want to see if this subpopulation of myeloid CD117 positive hepatotype is associated with differential responses towards different biologic therapies, especially for those using IL-17 or IL-23. So here's the method. So they have a synovial biopsy cohort, and they have 15 of them were labeled having this CD117 phenotype. And in this 15 patients attend use IL-17, we use IL-23 to use TNF. And we compare this cohort with clinical control cohort with 30 patients who started with TNF or IL-17 inhibitors and or IL-23. So here's the results. So that in typical age of 50s, and half of them were male, and they have moderate skin disease and also moderate deficit, and the comparable disease characteristics at the baseline. And the primary outcome was achievement of low disease activity or remission according to deficit. So from the blue bar here, after 1 year, actually 68% of them in the biopsy guided group actually achieved the primary outcome, and it was significantly higher than those in the standard approach, which were only 45% achievement. And when they are looking into the myeloid CD117 positive subgroup, and they see a greatest reduction of steps at 6 months in the anti-IL-17 group. And it was also having a marked reduction in the IL-23 inhibitor groups when compared to the TNF group. And they also look at the treatment retention, and it was also higher in the biopsy treatment group as seen in the blue line here at both month 6 and also 12 months. And finally, they also looked into the synovitis score from the biopsy, and actually it was higher in those clinical responders when compared to the non-responders. So this suggests a direct association between the intensity of synovial inflammation, infiltration, and also the clinical improvement. So to conclude, this study is actually a real-life proof of concept study that shows that a synovial biopsy-driven strategy is associated with a better clinical outcome when compared to standard strategy. And patients with myeloid CD117 positive subset showed a greater response for IL-17 and IL-23 inhibition when compared to TNF blockade, and this support the role of synovial biology in guiding the drug selections. And actually, this gives us more information additional to our standard way of making the decisions. And this may be approached towards personalized medicine using tissue-centered precision um, biology. So thank you very much, and I hope this would not be too difficult to understand. And thank you.
So thank you very, very much, Isaac. Very well presented. And I think, even some of us like me that I'm not involved in basic research, you just made me understand very, very well, what was the question and what these studies actually offer. And they were very, very interesting, especially, the last one when we are talking a bit more about, the field of precision medicine and what we can do better. Thanks again. We have also here Marlene, who is able to join us, and we would love to hear your comments and your questions. And of course, to all of you, feel free either to raise your hand or you put your question on the chat box. And we look forward to hearing from you. So, should we start with Marlene first?
So thank you, Margot, for the kind introduction. I think Isaac showed very nicely what indeed questions in the field led to these various studies. And I think, there are several topics he addressed. Like you mentioned, the last study was mainly on how can we improve the results that we have with the various treatments. I think this is a nice study that shows the first step. I think, as the authors of the abstract show discuss very well, is that, of course, further studies need to be done to really see, will this bring us something for the future? But I think it's nice that steps that some things we've seen in RA are also now applied to psoriatic arthritis. And I think we can learn from that. And if we will ever use it in the future, we have to see. But I think it's a way forward. So I think that's really nice. And I think from the other apps, the second one, of course, is when you think of psoriatic arthritis destruction, what is causing that? How do these cells come there? And I think they very nicely showed in that study that really these types of cells come into the tissue and they have a role in the bone remodeling and destruction. So I think it's a really nice that it learns us on how our disease is starting and how it comes to structural damage. And the first one is even early in the disease phase to really understand how we go from psoriasis to psoriatic arthritis. So I think these three abstracts really give us from very early disease to the onset of inflammation and mainly damage, and then how we can deal with this maybe better when applying our treatment. So I think this gives some brief insights there.
Yes, thank you so much, Marlene, also for contributing with your perspective on this. And thank you again, Isaac. I think very well selected and presented. I mean, to be very honest, I think you chose the hot topics on psoriatic disease here, right? I think this is something that we can really say with the disease interception, and I think especially in this interdisciplinary group, and this is where most likely Margot can align perfectly, because she will be most likely being the one that sees our patients the first. So I think to be able to, with some modalities, imaging, biomarkers, whatsoever, to identify those patients at a very early stage, maybe even treat them preemptively and prevent the disease outbreak of psoriatic arthritis, this would be the holy grail. And I think this is also shown that This abstract selected and presented by Isaac here received the award for being one of the most important abstract at the EULAR Conference. And then also you all know that difficult to treat, complex to manage, treatment refractory disease in general is a very hot topic in the community, and is very close to my heart as well. And I think if we would be able in the future to identify patients, if they will respond to any specific mode of action, and that we can make a treatment selection based on whatever biomarkers available and increase the likelihood that the patient is benefiting from a treatment that we are starting. I think this would also be something that would really be a game changer in clinical practice. And I'm very happy that we have Wendy here, because I think you most likely will agree, but also can contribute with a unique perspective being a patient. And because I mean, here at least the last abstract sounds very promising, but we are also not the ones that would have to have the synovial biopsy. So maybe Wendy, you can contribute to the whole presentation, but also on this topic specifically.
Yeah, thank you, Fabian. This is exactly what I wrote down and what I was questioning and also a bit worried about on the final presentation. Because of course the biopsies, I can imagine, if I understood correctly, that this is the injection directly in the joint, right? And I think it would be great if we can, of course, do the precision medicine and get better treatments directly available and see what works for who. I'm very fond of that, and I would be very happy if that works. But I was wondering, and Marlene, you already said a bit about this, that they were talking about future work and stuff. Did they also mention a bit about how this would look like in clinical practice? Because I would be a bit worried if we need to do a biopsy for every single patient to see what works. I mean, I can imagine some patients just rather start their treatment instead of doing a biopsy. So I'm just curious if they mentioned anything about it, or maybe if you have a comment on that, because I'm actually a bit worried about that.
Yeah, so I can comment on that, but maybe Isaac, as presenter, maybe he can comment first, if that's okay with you.
Yeah,
Yes,
so
definitely.
actually they are having a very a proof of concept study. So this is mainly for research, for us to understand what's actually happened inside the tissue. So I think in real life, I think we can't say what will happen in future, but I think in a more practical way would be we also find other biomarkers in the blood which also correlates with the biopsy data, then that will be a more practical way in clinical practice, and for us to stratify who will respond to which treatment. So I think with the advancement of technology, that may be a more feasible way instead of having an invasive biopsy for everyone. So that's my view.
Yeah, and I think indeed, so I align with Isaac, and I think with the presenters, they did not mention this aspect specifically, but I think it's a broad in the field within rheumatology. I think also with the studies in RA, this is a topic of concern, of course, and we've in Amsterdam, of course, have quite some experience also in synovial tissue biopsies. And what was striking to us when we asked the patients who have undergone these studies how the burden was for them and if they would do it again, it was very well tolerated. And I think that is something, it's not for everybody. I think it will never be. And indeed, if we can find markers in another way, imaging, blood, easily accessible, of course, that makes life easier. But I think in general, these procedures are very well tolerated. And of course, then you really have to have a really high certainty that it will really benefit the patient, that you are certain. Then it might be something that can be applied, but of course not on everyone. But I think it was good to know that this is not by the patients undergoing these procedures, is very well tolerated and well perceived. It was in our study similar to undergoing an MRI. So that's something to think of also.
Absolutely agree. Two short comments from my perspective. First, there was also last year at ACR an in-T-cell biopsy study presented by the Erlangen group, and here patients were doing repetitive biopsies of the enthesis. So the patient came back to receive another biopsy of the same enthesis at a later time point, showing that they were at least tolerating it in a way that they came back to the center. And thirdly, I mean, when we are speaking about precision medicine and we look to other disciplines and we are speaking about gynecology, wherever patients for breast cancer, they all have a biopsy before they underwent treatment, and so they can really see by the biomarker which therapy will be selected based on the pattern, based on the hormonal status. So I think this is something, it might even be something in the future that we just do in clinical routine, not tomorrow, but maybe in a couple of years from now. And I think if this is really then significantly increasing the likelihood, and as Marlene said, the patients were tolerating it quite well. And if you're doing this biopsy of the synovial tissue, you can at the same session also inject steroids and do further analytics. So I think this can be something that could really be combined. Thank you both for. Oh, sorry, Marlene, you.
No, I think I completely agree. But I think indeed, as Wendy mentioned, like in the future, if we would go also, then I think for us as rheumatologists, we have to keep asking the patients if they still feel the same, if we would do it on a broader scale, because I think people participating in studies may not be the ones reflecting the whole community. So I think it's really good point, Wendy, that we have to be aware of even what we see in studies might not still resemble what all people suffering from this disease feel. So it's something to keep studying, be in discussion with each other. So really the valid point there.
Yes, thank you all so much. Thank you, Isaac and Marlene, for curating and presenting. Thank you, Wendy, for your contributions and all for the vibrant discussion. And without any further ado, I think we can move on. And I'm very happy to now introduce Andre Ribeiro, current chair of Young GRAPPA, and not only a colleague, but a great friend of mine. And I think it's very easy and we can save some time because Andre really doesn't need a long introduction. Andre, I'm very happy that you're here and that I will be able to listen to your presentation on treatment that was supported by the supervision from Ennio Lobrano. And yeah, really looking forward to your presentation.
Thanks, Fabian. Can you see my screen well?
Yes, perfectly fine. Thank you.
So thank you, and thanks for the introduction. I am happy to share the Congress highlights regarding the treatment session, which was developed with the help of Professor Ennio Lobrano. Moving along. These are our disclosures. So the session today will be mostly around two topics. The first one regarding the importance of obesity in the management of psoriatic disease, and the second one focused on new treatment strategies, not to mention that treating obesity is already a new treatment strategy, but the second part more focused on how to combine biological treatments. So just a brief review. We already know that obesity really influences outcomes in psoriatic disease. We have the inflammatory cytokines that are produced in the adipose tissue. They increase the risk of developing psoriasis, progressing from psoriasis to psoriatic arthritis. And when we have established psoriatic arthritis, to not achieving the main outcomes that we would like to achieve. Examples such as PASI 100, ACR 50, MDA, and many other outcomes that we pursue in trials and in our clinical practice. So we have this mechanistic plausibility that if we would treat obesity, in addition to treating the patient with a approved advanced therapy for the psoriatic disease, we could maybe improve these patients' outcomes. In addition to that theoretical plausibility, we also had a new sub-analysis of the SPEED trial presented in EULAR 2026. So just to remember, the SPEED trial was a strategy trial presented by Laura Coates last year, where in early diagnosed PSA patients that were treatment naive and had poor prognostic factors, these patients could be randomized to the standard step-up care anchored on methotrexate, early combination of conventional DMARDs or early combination of methotrexate with a TNF inhibitor. Sorry, my cat really wants to be around. The headline from the SPEED trial itself was that the more intensive early strategies paid off, meaning that by week 24, both the combination of conventional DMARDs or the combination of methotrexate with early TNFI led to higher PASDAS, good response. But by week 48, only the combination of methotrexate with adalimumab still kept the superiority compared to the standard step-up care. What we had new this year was the presentation of the SPEED sub-analysis, where they used recursive partitioning, a machine learned model, to approach and rank the predictors of 1-year PASDAS to really find which variables mattered most for achieving remission, including all variables that are shown here, such as BMI, baseline PASDAS, treatment allocation arm, joint pattern, sex, age, and many others. The result is the headline of this whole block regarding obesity, where BMI outranked all other factors, including treatment group allocation, as the dominant predictor of the 1-year joint outcome. And even though this is a post-hoc machine learning analysis, which has the caveat that infrequent events and infrequent variables may have a very strong impact, it really aligns with the recent reframing of obesity, moving from just a comorbidity to a variable that needs to be treated alongside the use of biologics. In that regard, we had 2 studies presented. First, the DIPSA study, and then the Together PSA study, which looked into the question that if we change the weight, do we change the outcome? So first, the DIPSA trial that was presented by Leahy with Alexis as a co-PI is a randomized controlled trial of a dietary intervention in PSA, where patients were randomized to the DASH low-caloric diet versus a Mediterranean diet with focus on diet quality instead of losing weight, and controls, with the primary endpoint being DAPSA change at week 24. Here we can see the primary outcome, and what we can really see here is that diet improved DAPSA and MDA at week 12, with incremental gains at week 24. Nevertheless, all diet interventions really improved outcomes, which is a positive finding, but was unexpected when the trial was being developed, which raised the mechanistic question about what was the driving factor behind this improvement. Was it the diet itself or other factors? So they looked into weight to see if losing weight was really the driving factor. And in fact, it does seem like that. We can see in these forest plots that patients that lost more weight were those patients that really had an improvement in DAPSA, pain, and MDA. So if weight loss is the most important component of a diet in regarding to improve PSA outcomes, that really leads us to the Together PSA study, which is a phase 3B randomized trial that enrolled adults with psoriatic arthritis and obesity or overweight with a comorbidity. And it compared the use of ixekizumab plus tirzepatide, which is a GLP-1 GIP dual agonist, versus the use of ixekizumab alone, with a primary endpoint of ACR50 plus 10% weight loss at week 36, but with more interesting secondary outcomes such as isolated ACR50. Here we have the baseline characteristics of those patients, which I kept here just to highlight that these patients were indeed obese. The mean BMI was 38 and 37 in both groups, and at least 65% of them had failed one prior advanced therapy. So overall, it was a more difficult to treat population than normally included in the RCTs that we usually see. Here we have the primary efficacy endpoint, where without surprise, the combination therapy achieved more weight loss, since ixekizumab does not look very good for losing weight. But more interestingly, we have that the isolated ACR50 response had a delta of 33.5 versus 20.4, meaning that using tirzepatide in addition to ixekizumab led to more efficacy in this study. And we can also see from the curve trajectories that this difference appeared very fast, with the curves already separating at week 4. So to finalize this first block, more focused on obesity, we have that first, obesity is not really a bystander in PSA. It really impairs skin and joint outcomes. This was solidified by the speed trial sub-analysis, where BMI outranks treatment group allocation as a primary predictor of one-year joint outcomes. And both the PSA study and the Together PSA study showed that tackling obesity with addressing weight loss specifically led to improved outcomes in psoriatic disease. But now moving on from obesity to the drug level decision, we have very interesting studies presented as well, starting with the Be Bold study, which is a head-to-head randomized trial in active PSA comparing bimekizumab, a IL-17A and F inhibitor, against risankizumab, an IL-23 inhibitor. The primary endpoint was ACR50 at week 16, with outcomes followed up to week 24 and a safety follow-up up to week 32. The primary endpoint, which was ACR50, was met, meaning that bimekizumab was statistically superior to risankizumab for ACR50 at week 16. And we can see the curve trajectories up to week 24, showing that this superiority in ACR50 was kept until week 24, with 54.9% achieving that in the bimekizumab group versus 43.8% in the risankizumab group. Regarding secondary outcomes, they had the issue that the first hierarchical outcome was MDA achievement at week 16, and this secondary outcome was not met, meaning that the hierarchy was broken because the first secondary outcome did not achieve it. So all other outcomes followed a nominal p-value and not a significant p-value. That said, many other secondary outcomes had superiority at week 16. For instance, ACR50 plus PASI 100 at week 16, as well as PASI 100 isolated at week 16, even though for those outcomes that considered skin, those composed outcomes that considered skin outcomes as well, they usually got closer around week 24, showing that risankizumab was tagging along a little bit more at that stage. From a safety perspective, it was reassuring that no new adverse events were found in this study, and the only between group difference was that Candida infection was more common in the bimekizumab group, as expected. So to summarize, Be Bold, it was the first head-to-head trial to demonstrate superiority from a joint-focused primary endpoint, in other words, ACR50 at week 16, with numerically higher proportion of patients achieving other secondary outcomes at week 16, including a PASI 100 at week 16, but again, nominal p-values, and safety was comparable between groups. The next trial I'll talk about is a sub-analysis of the Affinity trial. The Affinity trial itself is a phase 2A trial testing combination target therapy of guselkumab alone versus guselkumab plus golimumab in patients with an inadequate response to a TNF inhibitor. And what was presented at EULAR was the MRI data at week 24, which was a planned sub-analysis. But before going into the MRI data, it is important to review the main outcomes from the AFFINITY trial itself. The primary outcome was MDA achievement at week 24, and this outcome was not met. The combination was not superior to guselkumab alone for achieving MDA, even though the combination was superior, again, p nominal values, for achieving ACR20 and ACR50. And these differences were mostly due to patients with elevated inflammatory markers, such as elevated CRP levels. And we can see in the forest plot that these patients that had elevated CRP were much more likely to benefit from the combination, for instance, regarding ACR50 and MDA in comparison to those that had low inflammatory markers, such as low CRP. But going back to the results of the MRI sub-analysis, here we can see that patients in the combination therapy in dark blue and guselkumab alone in light blue. Here we have the individual trajectories and the stacked plot showing that the patients in the combination group had a more significant decrease of the total inflammatory score in the MRI. A caveat is that they had higher inflammatory levels at baseline, so this might skew the analysis. And the structural damage was similar in both groups and didn't change across time. Here we have the cumulative changes, which tell the same story in an aggregate manner, where we found that greater inflammatory reduction with the combination and structural scores maintained stable over time. So as key takeaways, we have that the combination with guselkumab plus golimumab produced greater reduction of inflammatory scores in finger and toe than guselkumab alone, with structural changes remaining stable over time. And as I said, the critical caveat of this study is that the combination group had higher inflammatory activity than the monotherapy group at baseline, which can really skew the analysis because this apparent advantage may be just the regression towards the mean rather than a true additive effect, which makes these results more exploratory and hypothesis generating. A new study that is exploring the combination of advanced therapies is the combo study. In EULAR, we had its design presented as a poster where patients with a failure to a TNF inhibitor therapy will have deucravacitinib, an oral TYK2 inhibitor, added to the TNF inhibitor in comparison to adding a placebo and keeping the TNF as a monotherapy. The primary outcome and secondary endpoints will be analyzed at week 24 with an open label safety period up to week 48. And this is really to complement the data regarding combination advanced therapies in psoriatic disease. So we are eagerly awaiting for its results. Here is just a summary bringing everything together. So we have that obesity really impair outcomes in PSA, and it's not just a comorbidity anymore. It is a variable that we need to address, as showed by the DIPSY study and the Together PSA studies that both show that losing weight led to better outcomes. We have the BBOLD study, which was the first head-to-head trial to demonstrate a joint endpoint being superior with one mechanism over another. In this case, bimekizumab superior to RIZA for ACR50 at week 16, and the AFFINITY MRI sub-analysis showing exploratory data and hypothesis-generating evidence that a dual blockade may reduce joint inflammatory burden beyond IL-23 inhibition alone, with the combo as a next step regarding combination therapy. Here are is the reference list for everyone. And thank you for your attention.
Thank you so much, Andre. Wonderful presentation. Thank you also to you, Ennio, for supporting and selecting these abstracts. Great selection. Honestly speaking, and I think from the psoriatic arthritis disease perspective, it was a very fascinating conference and really advances in the field. This can also be seen that in the late breaker session and the plenary session, there were topics about psoriatic arthritis. And so the overall rheumatological community was exposed to our data. You know that I have strong, very strong heart for the abstracts that you selected, and having now also head-to-head data on PSA again. I think the last one is 5 years ago, something like this, with the Spirit head-to-head. And the first time that we have head-to-head data now available for a comparison to another mode of action than TNF shows also that how we are advancing in the field, because all previous head-to-head data in SPA in general was always comparing to TNF, and this is the first time. So I think also the title of Be Bold is really was really the core message that they were trying to be better. When looking at the curves, I would be very curious also to see how the long-term follow-up looks like, because it somehow indicates that maybe Risa only needs a bit more time to become as effective as bimekizumab, but also for the patients having these very strong options available and being able to make a very subtle selection, choosing one over the other based on these head-to-head data is really important for our clinical practice, and I think will change the way that we are treating our patients. We were speaking about treatment refractory patients that were trying monotherapy, different modes of action, and were not responding in a way that we are aiming and hoping for. And so we end up that in clinical practice, we need to do combination therapies, and having both the affinity and the combo study results available, both for safety and then also efficacy, will be really important for us when making treatment selections. And a very hot topic, GLP-1 agonists in general, and combining those with a biologic. I think this was very everywhere at the conference. There was also a poster that I really liked from Jeff Curtis about huge data set, I think 20,000 patients with psoriatic disease under treatment, where it was really shown that those with reduction of the weight benefit clinically also from their PSA. So I think this is something that we have to have in mind as rheumatologists, and specifically here in Germany, currently we rheumatologists are not using GLP-1s very often. This is more in the home of the endocrinologists, but I think this is something that we have to do based on these data seen. So Ennio, I also want to invite you on stage and maybe support this with your perspective. And as always, Wendy, really happy to hear your perspective from the patient side.
So first of all, thank you to all of you. And for me, it has been a pleasure. And it was really a win-win because Andre did a fantastic job. Fantastic job in selection of the abstracts, in the way he presented, in the way he made the conclusion. So everything is very clear also for the young people attending. So thank you so much. The point is, always we are involved in new trends, but sometimes we are think about what's happened beforehand. So now it sounds that everything is all about obesity, like we are moving towards to be endocrinologist or diabetologist. But I want to, because I'm older than you, remember that we had a fantastic honeymoon of more than 25 years in which eventually rheumatology identified some inflammatory cytokines to control the disease. In fact, at the end of the day, the Together study per se shows that ixekizumab is not bad as a treatment for psoriatic arthritis. A different story is when you have an obese and super obese person, you need obviously to give some advice on lifestyle as much as you can, or potentially in Italy it's not possible to prescribe tirzepatide as a rheumatologist. So the idea of this study is very interesting, but the message at the end of the day is not the quality of food, it's the amount of food and the weight loss. And in fact, nothing's new because even a few years ago, the Swedish group taking patients on 640 calories, they had a fantastic, improvement on DAPSA. And again, my perplexities is all because everything is all about pros. So the patient perception of the global assessment of the disease sometimes can be confused by other condition. And obviously, being overweight or obese could be really a severe problem also from mechanical point of view. So I don't dispute that obesity is a source of inflammation, but overall, when we treat patients for the inflammatory components of the musculoskeletal disease. This is my first question. Then maybe Andre can reply quickly on the combination, very interesting combination treatments. We are moving towards combination treatment, but in the meantime, we don't know what's going on in terms of potential biomarkers. So it's another way, it's another trial and error. Trials combining, two medications, hopefully treating better patients. Third, be bold. Actually, is at the moment is, let's say, the first real head-to-head in a way that the endpoints was a true musculoskeletal endpoints, endorsed by FDA and EMA. The only perplexity again, and Fabian already pointed out, let's wait a bit, just in case risankizumab sometimes is a slow coach. It takes a while to control the disease. These were the first release of 16 weeks. So I open this potential discussion or comments because the presentation are very good. Topics very interesting, data fantastic, but we are not reinventing the wheel. Obesity is a problem, but we are rheumatologists. We should think how better we can control this patient if we have the chance, but without losing our identity of rheumatologists by using treatment to control the major source of inflammation. I don't know who wants to be part of this discussion at this point.
No, I do fully agree. Thank you also for sharing this perspective, Enyo. Wendy, what are your thoughts on the abstracts presented?
Well, first of all, I think it was an amazing summary. Thank you, Andre. I heard a lot of people as well talking about psoriatic disease. I think indeed, Fabian, we were everywhere, so it was great to see EULAR. I specifically actually have a question as well, because looking at the final parts about combination therapy, I heard a lot of people talk about it. It's very cool, and I can really see the potential for people that have disease that is not really under control. But I'm also a bit worried about long-term side effects and maybe even over-treating patients. But if I understood correctly, it's only the data for until a certain weeks, right, Andre? And maybe you can comment on this because I'm just curious to hear your thoughts, or maybe something was mentioned that I missed.
No, you didn't miss anything, Wendy. You're very up to date as usual.
Yeah, but I wasn't at the
Uh,
presentation, so I thought maybe.
but no, yeah, we don't have long-term safety data for these combination therapies as of now. And the fact that first we are looking into efficacy and also short-term safety data, because we didn't have even short-term safety data until very recently that we are now developing. This study found short-term safety, and even though it didn't meet its primary outcome of MDA, many secondary outcomes, including ACR 50, had a difference, but that we can only look from a phenomenal face value because the primary one was not met. The main issue is just like Ennio mentioned and as Isaac presented before, is that we are still doing a trial of just testing one drug, trial and error approach. And this leads to many times prescribing a drug that will not work we do need to improve in that regard. That may be biopsy or blood biomarkers. I'm also just publishing a case series of 24 patients using combination of advanced therapies. There, we did have a median follow-up of 450 days with no new safety issues, but still a year and a half of follow-up.
That sounds promising.
Yep.
Yes, and there's one more question coming from the audience. So GLP-1 has GI side effects, including biliary. Has the combination look at which PSA better choice due to gastrointestinal problems? Also, which GLP-1 should be administered? And I think this is a question that makes complete sense. But based on the current data available, we can't give any clear recommendations in one direction or the other. First, the risk of side effects was not much higher, so I think this is something that we can relax a little. Secondly, if one biologic or one GLP-1 has a better safety profile when being combined with the other is not clear yet, and I think this is something really that has to be determined in the future. So thank you, Andre. Thank you, Ennio, once again, and also to you, Wendy, contributing to the discussion. And I think, Margot, we can move on to the cherry on top.
Yes. So after this excellent presentation again from Andrea, we're moving forward to our next Y-Grappian, last but not least, Daniela Tovar, who is going to focus on the clinical topics from the EULAR Congress. Her mentor, her supervisor for this presentation has been Philippe Caron, and we're very happy to have both of them here. Daniela is an internist and rheumatologist based in Lima, in Peru. She's an active member of Y-GRAPPA. She serves the social media committee, but also the newsletter committee. And she's also a member of the Panlar Spondyloarthritis and Psoriatic Arthritis Study Group. And she serves also as a social media editor for the Journal of Clinical Rheumatology. We're very happy to have her here, and we really look forward to her presentation. Daniela?
Hi, thank you. Sorry, I'm going to try to share my slides. Can you view them correctly?
Yes.
Can you hear me right?
Yes, we can hear you.
Okay, perfect. So before I start, I would like to thank Dr. Philip for his guidance and support in selecting the abstracts that we will be reviewing today. For today's clinical highlights, we selected 4 abstracts that together illustrate the evolving landscape of psoriatic arthritis care, from disease interception to early diagnosis to disease assessment, and finally patient-defined remission. Here are our disclosures. And for the first abstract, I'm very sorry, I had a cough from a cold. For the first abstract, this one addressed the most exciting concepts in psoriatic arthritis research today, which is disease interception. While we have become increasingly effective at treating established PSA, preventing progression from psoriasis to PSAs remain as a major unmet need. So most previous studies have relied on administrative databases in which diagnoses are based on coding. So a major strength in this study is that both psoriasis and PSA were confirmed by a specialist in combined dermatology-rheumatology clinics, with PSA diagnosis made directly by a rheumatologist. So in order to evaluate whether biologic class is associated with different risk of progression from PSO to PSA, the investigators followed nearly 400 patients with psoriasis without PSA at baseline for a median time of 12 years. And in this cohort, around 22% of the patients ended up developing incident PSA. Not surprisingly, scalp psoriasis, nail involvement, family history, obesity, and smoking were common and more frequently on the patients who ended up developing PSA. So this reinforced the previously recognized risk factors for this progression that we already know. And to answer the central question of this study, which was, does biologic class influence the risk of progression from psoriasis to PSA, the investigator performed two complementary analyses. The first one, they evaluate patients who had been exposed to a single biologic class through follow-up. And in this analysis, incident PSAs developed in 45% of patients that had received TNF inhibitors, compared with only 14% of patients who had received IL-17 inhibitors or IL-23 inhibitors or IL-12/23 inhibitors, which was only 11% of these patients, which eventually develop PSA. And these findings could be reproduced when patients were categorized not only on the single biologic class through follow-up, but also according to the longest biologic exposure. So you can see in the Kaplan-Meier graphic that the curve shows a clear separation between TNF inhibitor patients and non-TNF biological classes, supporting a lower incidence of PSAs among patients that receive IL-17, IL-23, or IL-12/23 inhibitors. And finally, the investigators also performed a sensitive analysis restricted to patients treated from 2018 onwards, when all biologic classes were more broadly available. And these results also remain consistent. In this more contemporary cohort, the incidence of PSA was approximately 15%, and both IL-17 and IL-23 inhibitors continue to be associated with lower odds and hazards of incident PSA compared with TNF inhibitors. So in this long-term real-life clinical cohort of patients with psoriasis, treatment with non-TNF inhibitors, particularly IL-17 and IL-23 inhibitors, was associated with a lower risk of incident psoriatic arthritis compared with TNF. Of course, this remains as an observational study, and the possibility of channeling bias and confounding by indication cannot be excluded. So these findings should not be interpreted as a proof of prevention, but nevertheless, this study provides some of the strongest clinically characterized real-world evidence supporting the concept of PSA interception. Moving on to our second study, this moves us from disease interception to early diagnosis. So we know enthesitis is one of the defining features of psoriatic arthritis and a key element of current pathophysiological models. On the other hand, ultrasound has become increasingly important for detecting enthesial abnormalities, yet until now, there has been no validated ultrasound-based diagnostic score specifically developed for PSA. So the goal of the DUET study was to develop and validate a standardized ultrasound enthesitis score that could assist in the diagnosis of psoriatic arthritis. And this was a large international multi-center study that involved 17 international centers and over 400 participants. And the investigators included three clinically relevant groups: patients with early PSA, patients with psoriasis without evidence of PSA, and non-inflammatory controls. So early PSA was defined as patients fulfilling Casper criteria with less than 5 years of disease duration and who had never received biologic therapy. The psoriasis group included patients without prior biologic exposure and without evidence of PSA, which was defined by the PEST score below 3 points. And the control group did not consist on healthy volunteers. Rather, these were individuals that were seen by rheumatologists for non-inflammatory musculoskeletal complaints. So this provided a more clinically relevant comparison group. As you can see, the development of the duet follow a multi-step process, which I'm going to try to summarize as much as possible in sake of time. So all patients underwent a standardized ultrasound assessment of 16 endothelial sites, as you can see on the figure, both on the upper and lower extremities. And the investigators evaluated both inflammatory and structural lesions. Inflammatory lesions included hypoechogenicity, tendon thickening, and power Doppler signal, whereas structural lesions included calcifications, enthesophytes, and erosions. Then, the investigators first evaluated individual inflammatory and structural lesions across all endothelial sites and used a logistic regression model to identify the combinations with the best discriminatory performance. And you can see here in this table the top 8 performing scores among the 48 scores that were generated. And the best performing model included both inflammatory and structural lesions assessed bilaterally at the patellar tendon insertion, the Achilles tendon, and triceps, achieving an area under the curve of approximately 0.64. The final duet score incorporated ultrasound findings from these 3 bilateral endothelial sites that I mentioned before, the patellar, the Achilles, and the triceps. And the inflammatory component includes hypoechogenicity, thickening, and power Doppler, with power Doppler weighted 2. The structural component included enthesophytes and erosions, with erosions weighted 3 times. And these inflammatory and structural subscores are combined to generate a total duet score, which can range from 0 to 84 points. So after developing the duet score, the investigators, of course, evaluated its diagnostics performance and established an age-specific cutoff using 55 years old as a threshold. So in patients aged 55 years old or younger, a score above 5 points provided an specificity of 73% and a sensitivity of 49%. And in patients older than 55 years old, the cutoff increased above 11 points, yielding a similar specificity and sensitivity. The scores, of course, was subsequently tested in an independent validation cohort, where it showed a similar performance, but very interestingly, the sensitivity increased to approximately 63% in patients that had clinically tender entheses. And also, they found higher scores observed in PSA patients with obesity and those that were requiring treatment escalation as well. So overall, Duet represents a promising ultrasound-based diagnostic tool, particularly in patients with clinically suspected enthesitis, with an acceptable specificity and a moderate sensitivity. And one question that comes to my mind is whether Duet might eventually have applications beyond diagnosis. Given its association with disease activity features, it will be interesting to see if the score is sensitive to change and if it could play a role maybe in longitudinal assessment. The third abstract that we wanted to bring you today look at how rheumatologists assess disease activity in every PSA practice, in everyday PSA practice. So the Explore PSA study was a global survey conducted by John GRAPPA, so of course I couldn't let it out of these highlights, and it included nearly 700 rheumatologists and ¿cómo se dice? Fellows or trainees from 64 countries around the world. And one of the main findings was that DAPSA and DAS28 were the two most commonly used disease activity measures worldwide. When you take a closer look to the data, it reveals some important geographic variation. So in Latin America, it showed that the highest uptake of DAPSA, whereas in Europe and North America, it demonstrated greatest reliance on DAS28. And a particularly interesting finding was the difference between GRAPPA and non-GRAPPA clinicians. So compared with non-GRAPPA clinicians, GRAPPA members were more likely to use PSA-specific outcome measures like DAPSA and MDA. They were also more likely to adopt a treat-to-target strategy and also to evaluate skin disease themselves. And when respondents were asked about barriers to implementing disease activity assessment in a routine practice, time constraint was the biggest challenge reported by nearly 88% of the respondents, which I think many of us can probably relate to this finding, right? And other commonly cited barriers included questionnaire burden on the patient and lack of consensus regarding which assessment tool should be used. So the challenge in PSA may no longer be developing new assessment tools, but implementing them effectively in routine care. And while Explore PSA examined how clinicians assess disease activity and monitor treatment targets, this final study explored how patients themselves define and experience those same targets that are remission and low disease activity. So the REMIPSA study was an international qualitative study involving over 100 patients. 56% of them were women from 11 countries across 4 continents. And through focus groups discussions, investigators explore what remission and low disease activity actually mean for the patient from the patient perspective. So participants were asked 3 simple but important questions. What does remission mean to you? What does low disease activity mean to you? And which symptoms and outcomes should be included in your definition of remission? And as you can see from some of the patient quotes, remission was most often described in terms of pain relief, recovery of normal life, and restoration of daily functioning. And even some patients equated remission with the disease being gone or completely cured. In the qualitative analysis, pain emerged as the most important symptom influencing patients' perception of remission, followed by visible psoriasis and activities of daily living and stiffness. But interestingly, many patients consider some residual symptoms compatible with remission as long as they did not interfere with daily functioning or quality of life. For example, limited psoriasis in non-visible areas, mild but non-limiting pain, residual stiffness was often viewed as acceptable in these patients. And in low disease activity, this was generally perceived as a more realistic and attainable state by the patients, acknowledging that some symptoms may persist while they still allow the patient to live normally and participate fully in their daily lives. So these findings suggest that remission is not always understood in the same way by patients and clinicians. And it also raised an interesting question for me. How do we actually explain remission to our patients? And does that influence how they ultimately perceive and define remission? So these were the clinical highlights we wanted to share today along PSA journey from prevention to patient-centered outcomes, So thank you very much for your attention. Muchas gracias.
Thank you very much, Daniela. Very well presentation, very good presentation, very careful and very interesting selected abstracts. Philippe, would you like to make any comments? And then we will move on with our comments.
Yes, certainly. Thank you very much. And I believe that Daniela did a fantastic job in selecting all these very interesting abstracts. And also the way she presented these abstracts was really outstanding. So some impression from my side with regard to interception abstract. I think that abstract is really strengthens the growing body of evidence that the non-TNF blocking agents, particularly IL-23 and IL-17 inhibitors, are associated with lower risk of PSA development in patients having psoriasis. So I think these results are really supporting the concepts of the PSA interception also as a kind of treatment strategy. And I think that prospective randomized studies will remain essential to establish causality and to determine whether biological class selection can be implemented as more preventive strategies in individuals at risk. And then the second abstract, this is an abstract where I also was one of the co-authors coming from the DUET trial. I think this is a really important trial because enthesitis, we are still, as clinicians, pushing at enthesial sites to see whether they are painful. And if that is the case, we score them as enthesitis. And we all know that at least some imaging technique is needed to see whether there are inflammatory signals can be visualized there to actually say, well, this is a real true enthesitis. And I think the DUET trial represents methodologically very important step forward in the PSA-specific ultrasound enthesitis scoring. And it's also with clinically useful, I think, specificity, particularly in older patients and those with tendon diseases. So perhaps one of the limitations in my eyes is the modest sensitivity that has been seen with the best formula that came out of the different possible combinations, meaning that a negative DUET scoring does not exclude PSA. So that is important to notice that. And I believe that the proposed formula is well positioned to integrate in early PSA diagnostic algorithms, but it will require prospective longitudinal validation before we can really use it widespread in our daily practices. So, and then the Explore initiative, I think, from the Young Grappians, that provides also important data, I think, confirming that PSA-specific compositive outcome measurements remained underused in our daily practices, while DAS28, which is more a rheumatoid arthritis-derived tool, is continuing to filling that gap. And I found it equally important that only a half of the GRAPPA members use the DAPSA in daily clinical practice for evaluating their PSA patients. And I think there is therefore work to be done on two fronts. First, the non-GRAPPA members will need to be indicated to use more these PSA-specific outcome measurements. But second, and also very important, there is also work remaining among GRAPPA members themselves to increase the use of these PSA-specific outcome measurements in daily practice. So I think these findings clearly argue for simpler validated instruments, better digital integration, and also targeted educational initiatives, particularly for non-GRAPPA members to use more the PSA-specific outcome measurements.
Great.
Yes.
Other comments from my side.
Thank you so much, and also thank you so much, Daniela, Dani. It was brilliant presentation, and I do agree, and I think very important, and I again want to invite Wendy also to contribute with the PRP perspective, but I think it's very important that it's not only that we enjoy being part of GRAPPA and really look forward being in Lisbon next month to exchange scientific important studies and have also some nice time together, but our patients benefit if we are part of GRAPPA, right? Because we are doing more thoroughly assessing those patients. And I think specifically the interdisciplinary exchange that GRAPPA members are more likely to also assess the skin is a very strong argument to be a part of GRAPPA and join and really benefit from the interdisciplinary exchange. So Wendy, from the clinical topics, what are the things that you
Well,
want to...
actually, almost nothing to add to what you just said, Fabian. I think that's a great comment. And to add to what Philippe was saying, of course, my favorite presentation was the final one. Thank you, Daniela. I think you did a perfect job, and very nice that you also brought this study to our attention. I very much enjoyed seeing all these remission that patients think the definition should include. And just like you, I would be very curious to see what we can do next with it, and also how clinicians can explain it better to their patients. So I think a lot to do for the future as well.
And actually, just a comment also for the last abstract, it's really focusing on this shared decision making. So at the end of the day, no matter what we say as clinicians, as dermatologists, as rheumatologists, with all these scores, what matters to the patient may be something completely different. So that's why we need the patient's perspective. We need to listen more actively, have also more patient-reported outcomes apart from the clinician-reported outcomes, put all of them together and go together, and support all of our patients, in this journey. And we are there together.
Yes.
Cool.
So I think we are at the half past the hour. We made it on time. I can only congratulate all of you for the brilliant presentations and thank you all for supporting or presenting, selecting, because I know that this is tremendous work that you have all created here. Very importantly, if you were not able to attend or if you found it so interesting that you want to share it with your colleagues, the recording of today's meeting will be made available on demand on the GRAPPA website afterwards, so you can currently share this with your friends and colleagues. And very importantly, as said, I always enjoy when I have the opportunity to get a little glimpse what is presented on the dermatological congresses. So EADV is up around the corner, and after summer break, we will have the opportunity to capture all the highlights that are presented from EADV 2026. So you can already mark your calendars for October 14th. And yes, Margot, thank you so much for supporting me today and co-hosting this session.
Thank you very much.
Thank you for your interest and all presenters and senior GRAPPA members. And specific thanks to you, Wendy, also for contributing with the patient perspective. And most importantly, thank you so much to Annie and GRAPPA administration to make all of this possible, because without your support and technical guidance, we would not be able and would still sit in the dark. So thank you a lot for that. And so I can close the session. Thank you and bye-bye.
Thank you, everyone. Bye-bye.
Thank you. Bye-bye. Thank you. See you
Thank
soon.
you. Bye.
Bye.
Bye-bye. See you
See you
soon.
Bye-bye.
in Lisbon. Bye.